He turns his head to the side, and it was like horror movie.
He had an appendicitis, and he had a necrotic appendix. That's actually what ended up being his worst problem.
And that's why he was vomiting.
You are listening to EMS with your hosts, Erik and Matt Ball.
I'm not really sure about this whole leech idea that you come up with.
Well, so it started with that vitology book from the standard medical practices of the 19th century, in the 1800s.
Which, side note, is for us old people, from the Vitology album from Pearl Jam from the early 90s.
That's right.
Most of the young kids are out there like, what's a Pearl Jam? What's Vitology?
Right.
But anyway,
I own that album. That was good.
That's a great album.
So when I saw the cover of this book, I was like, that's where the cover came from. I didn't know that. That was cool. But the cool part about the leeches, it's actually two things I think that are pretty cool about the leeches. Back in the 1700s, even earlier in Egyptian, medicine, they would use leeches for bloodletting. Yeah, and it became the standard of care for medicine. And in fact, it was so associated with medicine that in Old English, the word for doctor they derived from leech.
Really?
Yeah, I can't. It's a weird spelling, but I guess there's a common word, origin in the Old English, liaise or something like that, which was really because of the association people made with leeches and medical care.
It should have been more for attorneys that they would be associated with leeches, not doctors. Just kidding. Kidding.
But what's interesting too, as I was reading about it, they actually it created almost these leeches almost went extinct. The scientific name is Hirudis medicinalis or something like that.
Medicinalis.
Which reminds me of the second reason I think it's interesting, not only that they've been used in medical practice for centuries, and that they're still used today, which we'll talk about. But the other is the hirudin, I think it is. It's this compound in their saliva that is an anticoagulant. Yeah. Just to facilitate the blood from the host, if you will. And in the saliva, they've got peptides that are like an anesthetic, so it numbs the host, so they don't know that they're there. And then there's also another peptide that really increases blood flow. It stimulates histamine. And so you got the increased blood flow, the anesthetic, the anticoagulant, and these leeches, that's what they do. They suck that blood out. So what is the use today?
I don't know.
Well,
tell me.
Microsurgeries. So I had a patient once. He'd cut his thumb off in a dump truck door accident. The dump truck doors that slammed down, his thumb was in there, and that 1,000-pound door just took his thumb right off.
And that's a bad appendage to lose. Your opposable thumbs is what separates us from the primates.
That's right. So he was a gorilla for a while, and he became a human again because of these hand surgeons.
Because of the leeches.
Yeah. Well, the leeches are very important after surgery. So when you take when a microsurgeon, like a hand surgeon, or a microvascular surgeon, there's all sorts of different names for things. But the point is, when you repair vessels, when you're reattaching your thumb, you gotta, obviously there's going to be some structural things that need to be attached, and there's going to be some blood vessels that need to be reattached too, right? So those microsurgeons will reattach those the arteries. Arteries start pumping blood to the thumb right away. It's not a problem getting blood to the thumb. The problem are the veins. The veins take a while to heal and to start working, and so you'll get blood to the thumb, but the blood's not getting removed from the thumb, so you end up with a congestion problem. And so they put the leech on the thumb to pull blood out, to keep the circulation going. So the leeches have really become really crucial to the healing process of these, like that thumb, for example, that reattachment of the thumb. And so leeches have a place in medicine today, really important. A lot of people have that gentleman that I've got to see, his thumb was reattached. And so post-operatively, they keep the room warm. You got lots of like cotton gauze around his hand just to soak up the blood, and they keep replacing the leeches. Leeches will work for 15 to 60 minutes. And I don't deal with the inpatient management of these things, but there was very interesting to see the leeches saving that man's thumb. That's pretty
crazy.
Cool. So we decided, because of all of this.
What's this we? You decided.
Well, you and I agree that we like to find an engaging sort of a.
Well, GI bleeds isn't the most interesting topic
it's
either.
Not.
Yeah.
So in yesteryear medicine, they would use leeches to treat GI bleeds.
Mm-hmm. And where would they put those leads, Eric?
Around the anus and on the abdomen. And the thought was back then is that the GI bleeds were caused by blood congestion. So they want to remove blood to fix the GI bleeding. And as we know, as you're losing blood, pulling more away is really the answer.
Yeah, exactly.
So I thought that was interesting when I learned that, when I read that. So I thought, what a cool idea for our lectures to pull the medicine from yesteryear.
Yeah, I wished I would have now answered that call when you called me the other day and I was at work about, hey, I got some cold open ideas, so I could have maybe hedged this off.
Oh, yeah, that's right.
Yep, too late now.
Well, there are other things, too, they did to treat GI bleeds. Beef broth enemas.
Lovely.
They believed, well, even the causes, they believed it to be anxiety or, being...
the cause of a GI bleed?
Yeah.
Okay.
It's like mental things and spiritual things that were causing the bleeding. Some of the other treatments I thought that were kind of interesting too is they put you in a dark room with no sound, very quiet, and no stimulation. They felt like that had a lot to do with the bleeding to treat a GI bleed. It's just kind of ridiculous stuff. Back then, it wasn't ridiculous, though. It was standard of care. That was the medical practice journal of the day.
Yeah, right.
So
that's
it's
what they
interesting.
did. So we're talking about GI bleeds.
Yeah.
Did I ever tell you my GI bleed story?
No.
It wasn't a patient. I was the patient.
You were the patient.
I was the patient.
Let's hear it.
Yeah,
Did you use leeches?
I did not, thankfully.
Did your doctors use leeches?
I wanted to use anything because I can tell you the pain was not fun. This was May of 2020. We had actually had a get-together at the house. We had several members of my crew. We had some police officers, whatever. Anyway, we had a big barbecue at the house. Good Friday night, whatever. But May of 2020, so we are right at the beginning of COVID, right? So, hospitals and everything, we probably would have got shut down because we had people over at our house. Anyway, everything's fine, feel fine. Everybody leaves, go to bed at whatever, midnight or whatever. And I wake up and I've got this knot in my stomach. Not abnormal, happens, right? Feel a little bit nauseous. Anyway, go in, don't really get sick, but then I get this surging pain. So it's it comes and goes. And when the pain comes, it comes on strong. It's like an 8 or 9 out of 10.
Knocks you down.
I'm laying in bed and it's like a real bad gas pain, but painful. And it gets worse. And then it'll kind of go away. It's like, okay, it's gone away. We're good. 10, 15 minutes later, it comes back again. Oh, here it comes again.
At this point, did you have an idea what you thought it was?
I had no idea.
Did you have any thought? You're such a smart guy. I thought what the heck's going on?
No, I just knew. I thought, a gas bubble or just, I had no idea what was going on. So it progressively gets worse. Well, then I feel an urge to go the other, not vomit, but not to be graphic, but the other way, right? We've all been there with some medical podcasts. We can talk about these things. So I go into the bathroom and whatever, and this progresses. I have never sweated so much in my life. I'm not kidding you when I say I was balled up. This is like 2, 3 in the morning now. I am balled up on my bathroom floor. I am literally sweating from the top of my head to my feet. Every inch of me is just soaked in sweat. My wife comes in or knocks on the door like, hey, are you okay? I'm like, I'm fine. The typical male answer, right?
You are not okay.
I'm fine. Do I need to call 911? And I'm like, not just no, but heck no. We're not calling 911.
I'm going to die before you're going to call 911.
I'm not calling them out here at 3 in the morning for my bellyache. Anyway,
you actually probably should have.
I didn't realize it at the time, but so this progressed on and off for 4 or 5 hours. Just this pain.
That long? I didn't know you were there that long.
Yeah. I was on the floor, bathroom. It would subside. Okay, maybe it's bad. I thought it was just something I ate or whatever. Mm-hmm. And so finally, it was around 5 o'clock or so in the morning, And I kind of felt like the pain started to go away. And I thought, okay, maybe it was just something, it got out of my system. I'm good now. And I didn't want to keep waking up my wife, so I just went out and laid on the couch. I'll just sleep. I'm exhausted at this point from just not sleeping and the physical trauma that I just went to for the last 5 hours.
That's what happens when you're in shock.
And I'm dehydrated, right? I'm totally dehydrated. And so now I just have this dull ache in my stomach. But it's manageable. It's like 2 or 3. It's manageable. I can lay down and kind of get comfortable. Well, then I feel the urge to go again. And I go. And this time, as I'm cleaning up, it is nothing but blood. Bright red blood. And I'm like, oh, that's not good. Right? That's when I realized, like, oh, this is not good. There's something. So that's when I didn't want to freak my wife out. But I went in and I woke her up. I'm like, hey, I think you might need to take me to the hospital. And she's like, oh my God, because I don't ever, like, if I say I'm going to the hospital, like, I've chopped my arm off bad.
You basically told your wife you think you might die.
Yes, pretty much. So we get loaded up, and she's kind of panicking, but I'm like, I'm fine. And now the pain's starting to come back a little bit, and I'm like, okay, yeah, there's something definitely going on more than just a stomach ache. This is not just something I ate. We get in the car, and we're trying to decide, because the hospital that you were at, the hospital where she worked at, was about a 45, 50-minute drive, where the hospital that's a little bit closer was like I'm like, just go there. I'm like, I've got this pain has got to stop. I am in excruciating pain and I want it to end. Takes me to the hospital. It's COVID. She can't come into the ER. So I literally like walk in, doubled over into the ER, and I'm like, hey, my stomach's hurting. And they're like, okay, there's nobody in the waiting room, right? It's like 6, 7 o'clock in the morning. They were very good. Hospital staff was great. I was sat there for like 10 minutes. They got me. Guy comes, gets me, does a triage, gets me right in a room. Doctor comes in and, kind of does a quick assessment of what's going on. And so I tell him the story. And he's like, okay. He goes, well, we need to get you back to make sure it wasn't an ischemic bowel to where it was twisted, because that's like immediate surgery is what he was telling me. That's the biggest threat, right? Yeah. So that's what they wanted to rule out immediately. So he's like, let me get some orders put in. I'll get you some pain meds. Cool. The nurse came back in, guy nurse came back in. And he's like, okay, we're going to get a line on you. And he goes, and the doctor's ordered you tenomorphine. And I was like, tenomorphine? Like, I'm not a big guy. And I'm thinking, that's a lot of morphine, because I've given people like 2 milligram doses of morphine. Yeah. So I'm thinking, dang, that's a lot. I'd never had IV narcotic pain meds at all. Well, I can tell you, I know why people get addicted to.
It worked.
Oh my gosh. He pushed that in. And I mean, at this point, I'm like 7 hours into feeling a lot of pain. Yeah. And he pushed that, and immediately as it pushed into my vein, I felt this warmth just come up my spine, and just like everything just relaxed, like, oh, that feels so good. It's just like this warm sensation. Pain goes away. Anyway, ended up having ischemic colitis. I got admitted to the hospital for 4 days. COVID, wife couldn't come visit me, sat in a hospital room for 4 days. He said I probably just got dehydrated, and for some reason this just happened. He's like, he didn't really, I kind of followed
it. It didn't twist.
Did not twist. Yeah, it was not like, did not twist. It was just a ischemic colitis is what happened, but that was not pleasant.
If there's a doctor listening right now, I know I'm thinking, the classic board exam question is a lot of pain, like the worst pain of your life, but not tender. You push on it. It really doesn't hurt that bad to push on it. It's the pain you have this sky high.
Yeah, I had no tenderness.
Do you remember? That's
I don't remember having any tenderness.
See, that's a big warning for us. You get a patient that comes in with this awful abdominal pain, and then you push on them. It doesn't hurt, but that's terrible pain.
For what? What's that?
Ischemic bowel disease. Yeah, ischemic bowel. Yeah, you get the lack of blood flow to the gut. It's extremely painful, but not that tender. Painful. Yeah. So pain out of proportion minus any tenderness on exam, which is atypical, right? I mean, you get somebody with a bad diverticulitis or appendicitis. You get those peritoneal signs where it's a lot of pain, but
hit the heel.
Exactly, hit the heel, and you touch them. There's just a lot of guarding.
What's the point called? McBurney's point. Okay,
for appendicitis. Yeah. So you had that, so ischemic bowel, and you were in the hospital for a number of days, and that GI bleed, you had a lower GI bleed.
Yes, bright red blood.
Yep. So they would have, in yesteryear, they would have put some
leeches
on your anus and on your abdomen. We joke, but that was the standard of care.
Yeah, that's what they thought.
Yeah, and that would obviously
not
have
helped cancer. I mean, can you imagine, like 100 years from now, they're probably going to be like, when you got cancer, they used to give you chemo and radiation. I think about something like the poison that
sea collars.
Exactly right. I think about that sometimes, like, you look back 100 years ago, like cars were just invented.
Oh, I know.
Right now, look at all the technology. Just imagine. Anyway, we're getting off topic, but it's interesting. Leeches.
Yeah, so GI bleeding is a common thing that we can see. You can bleed from lots of different areas, but the GI system is a common place, very vascular. I think I read 20% of our cardiac output goes to the mesentery, the GI system's blood supply. And we need it too, right? When you eat something, the body's got to reabsorb and deliver the nutrients from our GI system.
Yeah.
So there's a lot of blood interfacing with our GI system. So you have a problem with the GI system.
Yep.
You can bleed pretty bad potentially.
And it's not always out the back. It can come out the front or out I guess one's an in hole, one's an out hole, not to be graphic, but it can come out of your mouth. You can get a lot of bleeding, and that can be GI bleeding. You get esophageal varices, which can be horrific bleeding. Those patients bleed like crazy from an inflamed liver, right? And then it backs up the...
It's usually a cirrhotic liver, like from alcohol. It doesn't have to be alcohol. There's lots of causes for it. And it causes a lot of increase of portal blood pressure. The veins within the portal, the liver circulation, called the portal circulation, causes a backup of blood, which can cause those esophageal veins to get really engorged and swollen and create varices. It's like a pouching of blood, and then it can burst, and you can bleed a lot. So you can bleed out your mouth, you can bleed out your anus, and there are two colors, black and red. So typically the blood that comes out of the mouth that's black, it's like a coffee ground material.
Emesis,
and that's usually from some sort of a bleeding within the stomach that's nice and slow, typically chronic. And then as it sits and as it sits there in the stomach, that acid creates a metabolite that's black. It breaks down that iron that's in the hemoglobin into a black substance. It looks like coffee grounds. And so you get this patient that's been vomiting up coffee grounds because blood's really irritating to the stomach. And you vomit up those coffee grounds, that's a sign that you got blood in your stomach, and that's one form of an upper GI bleed. You can also vomit blood that's red.
Bright red.
And you can also vomit up like a maroon colored blood, like a dark red, which would be like what you get from a variceal bleed from an alcoholic, for example. But I had a patient once, to tell you a story. This guy, he came in, I'm taking a history from him. He came in for vomiting blood. And he and I were having a conversation, just normal, just like you and me. And he was feeling nauseous. We got him some Zofran, and I'm a new doctor. This is 20 years ago. And I'm asking him questions, and all of a sudden he said, "I need to vomit." And so I got him a vomit basin, and one of those crescent shaped, like a moon, crescent moon shaped like vomit basins. Almost. It was not enough to hold the blood. He was about to vomit. He almost like projectile, bright red blood. And I said, "Oh my goodness,
not good.
This is not good." And so my nurse was in there. She got the attending physician. I was in residency at the time.
She said, "This guy doesn't know what he's doing. Get somebody else."
I was like, this guy was so sick. Anyway,
was he jaundice?
He was a little pale, but not jaundice. No. So he had undergone some radiation from some surgery, some cancer that he had. He wasn't that old. He's probably in his 50s, but he had some sort of a throat cancer. Anyway, and some of the radiation that he was getting caused an erosion between his esophagus, and I think it was actually way down in his esophagus. I think there was a communication with the aorta. So it's called an aorto-esophageal fistula. And so that
tunnel between the aorta and
tiny, it's almost like a pinprick, a pinhole spray of blood from the aorta into the esophagus, going down into his stomach. And the stomach would fill up with blood, irritate the stomach, and then he would vomit it up.
Which, by the way, is why you do not tilt your head back when you have a severe nosebleed. Because you'll swallow it.
Well, for this guy, super sick, he vomited up. Anyway, he got altered, and my attending and I decided this guy needs to go to the OR. We're intubating him now because he's vomiting so much blood. I think that little aorto-esophageal fistula, the connection between the aorta, a great vessel, and the esophagus, your food hole, food tube, not a good place to put blood. We intubated him, and I can remember that I had one yonk or whatever. I could not suck the blood out fast enough. And so we put 2 of them in there from the other neighboring trauma bay, and I got them intubated, got them to the OR. They needed some fast repair. He needed blood.
Yeah.
And so we were able to transfuse him and get him fixed up. But anyway, that was a bright red blood. So that's probably, like it was, arterial from the aorta.
Yep.
And that's so brisk and so fast that the stomach doesn't have a chance to really turn that stuff black. So bright red blood is usually acute, brisk bleeding. The maroon color or the dark red color is probably a venous bleed from like we said, a varice. And then the coffee ground emesis.
It's old bleeding.
Old bleeds, but sitting there for a while.
We had one very similar to that. We'd actually been on this guy before. He was a basketball coach, a big, tall guy. And we'd run on him before. I can't remember if he had cancer or what, but anyway, we went to his house and showed up, and the truck had got there before I was on the medic. We got there right after the truck did, and we walked in, and the captain on the truck walked out, and he goes, "It looks like somebody slaughtered a pig in that bathroom." And I'm like, "What?" And the guys on the truck come walking out. Like I said, this guy was like 6'5", 6'6", big guy. He comes walking out, and this guy is bright yellow jaundice. I mean, he is, and I'm like, "Oh man!" And he just looks sick, and I'm like, "Oh man!" So anyway, we get him on the cot, get him out to the ambulance. We're getting our vitals and everything. I'm looking for a line. Same thing, your guy.
Vomited up.
I'm gonna throw up. I gotta throw up, and I'm like, okay. And there was no time. I'm
bright
sitting
red
here.
Blood or...
He turns his head to the side, and it was like horror movie. Like, it wasn't even vomiting. He just opened his mouth, and it just poured out. I mean, again, I'm not trying to be graphic. And I was just like, oh my God. And it was bright red, just.
Oh, bright red.
Yeah, bright red, just. And I'm like, what is going on? And we tried to get a line on this guy. We could not get an IV. He was so sick. We thought about IOing him, but he was still conscious. Anyway, we ended up getting to the ER, and they were like, "Oh," I told the docs, I'm like, "You might have to IO this guy, put him down." And "Oh no, we'll get a line." I'm like, "Okay, bro. Like, I've been doing this a little while. I'm pretty good at IVs, and I'm telling you, this guy's got nothing.
He needs a central line."
Yes, exactly. Well, anyway, they ended up sticking him multiple times. Still couldn't get a lane on him. Finally, the doctor comes in, and he starts freaking out. "We need to get an IO." I'm like, "Oh, okay, Mr. Smart Guy. That's what I told you 10 minutes ago." But yeah, I think that guy ended up passing away. I don't remember what the underlying issue was. But I will never forget him turning his head to the side, and all I can remember is like horror movie level vomiting. And I mean, it took us 2 hours.
He was yellow.
He was bright yellow. Yes, and it took us 2 hours to clean.
I mean, we're talking like bright red. I don't have anything red.
Yeah.
on
Oh
me.
no.
Bright red.
Bright red. Yeah. Just. It was crazy. But yeah, so it's important as a EMS provider, you go on these, you're going to get called out to an abdominal pain call, right? Those are important questions to ask. Like, have you been vomiting? Have you had any diarrhea, loose stools, anything like that? And then ask them, was it bright red blood? Did it look like coffee grounds? That's a good way for a lay person to understand, right? Say, did you have bright red emesis? Like, what? I don't know what that is. Like, what did it look like? Those are important questions. Sometimes you look, especially if it's vomit, go look, right? Maybe take a picture of it to show the ER doctor. Like, that's very valuable information because that can tell you a lot of what might be going on with your patient.
The most common form of an upper GI bleed, and by the way, the definition is above this thing called the ligament of Treitz, which is right around the liver. Anything north of that is an upper GI bleed. Anything south of that is a lower GI bleed.
Is it upper intestine, lower intestine?
It's past the duodenum.
Yeah.
It's really high on most of the intestines are lower GI bleed.
Yeah.
But the most common cause of an upper GI bleed is a peptic ulcer. So you've been taking too many NSAIDs, too much Motrin or ibuprofen. Steroids can do the same thing. You basically end up, the true cause, I guess I should back up. It's really interesting. Your stomach acid can eat through the block of an engine, the metal of an engine. I mean, it's hydrochloric acid. This stuff is really powerful stuff. You might wonder, well, why in the world would we want that in our stomach? Well, we want it to be able to digest food. And we really need that stomach acid, especially with proteins, to break them down, to break those peptide bonds. So we need hydrochloric acid secreted by those parietal cells in our stomach. They make it, right? But we also have goblet cells within our lining of our stomach secreting a mucus. So we constantly are regenerating that mucus layer. As the acid breaks the mucus down, we make more mucus. It's just like, it's amazing, the system in the stomach to protect the tissue of the stomach and the muscle in the stomach from the acid. Yeah. Well, when you take Motrin, you slow down, because of prostaglandins, you slow down the mucus making process. So you're kind of hamstringing your, is that the right word? Hamstringing, like limiting the ability of your stomach to make mucus. And you do that long enough, you can actually get an ulcer. You can the acid can break through and eat at the lining of your stomach. And if you happen to get that ulcer over an artery, you can bleed pretty heavily in your stomach. You can also perforate the stomach and create a hole in the stomach with a bad enough ulcer, and that creates another problem with air in the belly. All that to say, these things can bleed. If it's a slow bleed, you get the coffee ground emesis, right? Yeah. You get a guy that you see him vomit into the bag, and it's like, that looks like coffee grounds. Yeah. Right? And you're looking at him, he looks pale. Yeah. He's been bleeding for a while. Yes. The scary ones are the bright red or even the dark red ones. You can bleed a lot of blood from a varice, from liver disease. But those are the different ways you can bleed out of your mouth. Risk factors for those things, obviously, chronic NSAID use. Alcoholism is big. And then, boy, you see any bleeding and a patient's on a blood thinner. We talk a lot about that in our lecture of blood thinners.
And a beta blocker.
Stuff the leech makes, right? And we've learned a lot from those leeches making, in fact, it's a thrombin inhibitor, so it's very similar to the blood thinner we would take called Pradaxa. Most of the blood thinners, they act on a different area of the coagulation cascade.
Yeah, right. But warfarin and Coumadin are kind of a broad spectrum. Would you put that term on it? They all the factors, where these other ones, Eliquis and
they are affecting the vitamin K dependent cofactors made by the liver, and then there are some of the other ones like Eliquis. They hit factor 10A. Right. I mean, anyway,
more targeted type.
Yeah, more targeted. That's right. And then you got heparin, you got Lovenox. I mean, there's a lot of different anticoagulants. The aspirin hits the platelet specifically.
Yes, platelet aggregate.
So anyway, the point is, the blood thinners, that's another risk factor.
So you have that GI patient, you have that abdominal pain patient that says they've been vomiting or said they've, had some rectal bleeding. Those are two good questions to ask when you're doing your sample history. That's right. What kind of meds do you take? And then did they take a LAL medication? Yeah. Or do they take a anticoagulant? Right. And even do you have AFib? Well, if they have AFib and it's diagnosed, they're probably on a blood thinner.
I'm glad you brought that up. Right. It's good to know the different medical problems that are associated with needing anticoagulants. So
just ties it all
AFib
together.
Is a big one.
Yep. Probably the most common reason why somebody's out of hospital, why somebody's on an
anticoagulant. Sometimes you get a patient that's like a heart valve patient.
Or has clotting issues.
Yep, that's right.
DVTs a lot, so they get put on.
Because when our body makes clots and breaks clots. Yes. It's a balance. Yes. And we want to be balanced. So if you have an INR or if you're balanced, it'll be 1.
Yeah, right. If you're too low, then you have,
Exactly. So if you have a risk like AFib, and we want to decrease our likelihood of making a clot. So we tip the scales towards clot breaking by taking an anticoagulant.
So you don't throw a clot.
But if you're grandma or grandpa and you're falling a lot, we don't want a head bleed. Nope. So the risks, maybe we balance it out, because the risk of AFib forming a clot, falling, hitting your head. So there's all sorts of risk tools in medicine to determine what we should do based on the literature. But that's not important for us to know in an ambulance. But knowing that a patient's on a blood thinner is important. Yeah. Now, we talked about the upper GI bleed. So about bleeding.
And I said upper and lower intestines. I meant large and small. Somebody's going to be like, "No such thing as the upper and lower intestines, idiot." So,
I would never call you an idiot. We all knew what you're talking about, because you've got the upper intestine, which is the small
intestines and large. Yeah.
And some of the upper intestine or the small intestine is part of an upper GI bleed.
Exactly.
And then most of it is part of the lower GI bleed.
Yes.
But most of the GI bleeds that come out of the anus, those lower GI bleeds. You can actually have blood from your anus and be an upper GI bleed too.
Oh, okay.
Yeah, because if you're not vomiting it up, you could swallow it, and it could get down into your GI system. And then by the time it gets to the anus, it's one of the forms of a GI bleed called melena, which is a black, tarry material, very characteristic odor of blood in the stool, melena. It's like tar. And so you get a real brisk bleed up top. It can form a GI, like a black tarry stool down below.
Yeah.
Typically, those types of bleeds, well, they can go either way. But,
right.
But if you have a black stool, it's probably an upper GI bleed.
Yeah. Right.
Coming out the anus.
Yes.
The most common lower GI bleed, though, is probably like a hemorrhoid.
I was going to say, yeah.
Internal or external hemorrhoid. Fissures can bleed too. Those anal rectal problems. But you can also have diverticula in the colon that can bleed. Colon cancers can bleed. I had a patient once in his 30s who came to the ER because of rectal bleeding. And he never got a colonoscopy. He had risk factors all over the place for colon cancer. Never got it. Should have gotten it.
Like family history and stuff?
Yeah, he had rectal cancer, and he just came in. He said, "Doc, I woke up feeling warm and wet, and I looked. I was red blood everywhere." And he came straight to the ER, and the CT scan that I got showed he had a rectal mass. And,
Isn't that what's the famous actress? She was the model back in the day.
Got colon cancer or rectal cancer?
Rectal cancer. She died. What's her? Anyway, sorry. She was she was blonde, like your typical California.
I'm thinking Christy Brinkley?
No, it wasn't Christy Brinkley. I think she's still alive.
Kathy Ireland?
No, she's not blonde.
Oh, I don't know.
Oh, doggone it. I'll remember it and it'll come back to me. But yeah, she got,
I'm so bad
was it
at
Farrah
knowing
Fawcett? I
movies,
think it was
sorry.
Farrah Fawcett.
Farrah Fawcett.
I think it was Farrah Fawcett. She got rectal cancer and, I mean, she passed away several years ago. But that's I mean, sad. That's a terrible way to go. I mean, cancer in general, period, is terrible. But
two colors. Yeah. 2 colors of bleeding. Well, really 3, but red or black. Black tar. We talked about that. The red ones can be maroon or red.
Right.
You get a nice varicele. I'm sorry, actually a hemorrhoid is basically a varice in the rectal varice.
Yeah, same.
And you bleed that way. But you can also have a bright red blood from your anus too, hematochezia, and that's not a good bleed either. It can be just as life-threatening as an upper GI bleed coming out the anus. So you need that GI doctor to find the bleed so we can stop it.
Yeah.
But oftentimes we have to transfuse these folks. In fact, where we've started the blood program, we've actually given a surprising amount of blood to medical bleeding like this, like we're talking about, that need the blood.
Probably a lot of OB patients, I would think, OB hemorrhaging.
Yep. So we've talked about the 2 upper and lower GI bleed presentations, and we've talked about some of the risk factors for them, and we really haven't talked a lot about management.
Yeah, I mean, again,
assessment really too.
Assessment. We talked about assessment, but obviously you want to ask, how long has this been going on? Are we vomiting? Do we have diarrhea? Was it bloody? What did it look like? Was it bright red? Was it coffee ground? Did it look like black tarry stool? All those important questions that we learned through paramedic school and EMT school.
Let me paint you a picture, Matt.
I'm
your patient. I'm your patient, and I'm nauseous, and I'm feeling lightheaded, and I've been vomiting up this coffee ground material, and I show it to you in my house when you come in to pick me up.
Sometimes they save it for us. Thank you very much.
Vitals look okay.
Okay.
Kind of borderline. Maybe a heart rate's 100.
Okay.
Blood pressure's 100 over 60. I'm talking to you on I'm ANO4 GCS 15, but I'm feeling a little bit lightheaded.
How's your skin color?
I look pale.
Okay.
What are you gonna do?
Well, obviously, like you said, full set of vitals.
Definitely.
Anything
else you want? What did I give you? Did I give you everything?
I think blood sugar probably.
Blood sugar's 100.
Temp.
98.6.
Yeah. So I'm gonna get you on the cot.
Yep.
Definitely thinking, okay, he's got some sort of a bleed going on, right?
Yep.
Definitely going to get a prophylactic IV, if he's been vomiting blood, or you said vomiting?
Yeah, I've had a
blood.
vomit, and I saw these black coffee grounds, and I've been told that that's blood, and I was worried. I called 911. Well, my wife was worried, right? That's usually the way the story goes.
Exactly. I don't need to go. Yeah, so definitely going to get some Zofran or something on board for the
Zofran's
nausea.
good.
Because the vitals are okay right now, I'm not overly worried, but I also want to know his past medical history and what medications he's on.
Yeah, great question. So, getting that. Yeah, if I'm a blood thinner, that makes you a little more concerned.
Blood thinner for sure.
Yeah.
And then is he on a beta blocker?
Yep.
Right? Because we know signs of shock. What's the first thing? The pump's going to speed up to try to maintain pressure, right?
Yep.
And so we're at 100, which is probably not his normal. He's
No.
probably 70, 80, right? So his pump's already sped up a little bit.
Yep.
So I want to know, like, and he probably wouldn't even be at 100 if he was on a beta blocker.
Right.
Definitely want to get a good history.
Yep.
Has this ever happened before? Do you have any family history of any GI problems? All those kind of questions.
And, you know, we're not really trained to think positively about these patients. We're trained to plan for the worst, right?
Yeah, right.
This guy's lightheaded. I agree with you. I wouldn't necessarily...
I'm not freaking out.
No.
I mean, his vitals are stable, right? But I do recognize that, hey, this guy could be bleeding internally and he needs to go to a hospital.
You would feel different if I vomited like that guy did. A bunch of bright red blood filled up a basin and all over, right? I mean, that's a different form of a bleed that's more concerning to us.
It's in a more acute...
Get to the hospital.
Yes, and I can't do anything. If you're bleeding out of your femoral artery, I can put a tourniquet on you.
Well, you got blood in your... Like, if you have
if
blood...
If you have access to blood,
you
right?
You can give blood, which is good.
And saline. What about saline? Should we give him saline or ringers?
Of course. Dilute the blood out. And no.
Yeah.
Yeah, well, that's a good question,
But, I mean,
Matt.
if my car runs out of gas, wouldn't I just put water in the fuel tank?
Absolutely.
Wouldn't that help me?
It's a great idea.
Yeah. No.
Yeah, no, yeah, and we know now not to do that.
Yeah.
So the blood pressure is falling because he's losing
Volume.
blood.
Yeah.
Now it's interesting though if I back up and look at the coffee ground emesis. So what's really neat about it's neat about the body's compensation. We haven't talked about this much, but the body makes a compound 2,3-BPG. Don't need to know what that is. But that actually increases the body's ability to offload. So these offload blood off hemoglobin, changes the oxygen dissociation curve. And so people who are chronically anemic can actually build more and make more 2,3-BPG so they can compensate and live at a much lower hemoglobin concentration than you and I would be able to survive on because they offload more. It creates a problem though, because if they have an acute bleed, they don't have much margin.
Yeah, right.
But that's how a guy can come into the ER with a hemoglobin under 2.
Oh, jeez.
He looked like Casper the Friendly Ghost.
Yeah, I bet.
And his blood looked like Kool-Aid. But he had been diluting.
Which, if a nursing school serves me correctly, I want to say the average for male is like 13-ish?
Yeah, 15 probably.
15? Okay.
13
Maybe
to 15.
female was 13. I think females are a little bit lower.
That's exactly right. Like 12 to 14.
Yeah.
I'm spitballing here.
Yeah,
but,
right.
But men typically have more blood, a higher concentration. Now, remember, the hemoglobin we measure, that is a concentration of blood.
Right.
It's right. If I bled out all my blood right now onto the floor into a 5-gallon bucket, that last drop of blood in my body that I left there would have a normal hemoglobin.
Exactly.
It's the concentration.
And your SpO2 would be 99%.
I'd be dead.
Yes. Yes. But yeah, just to put that in, what am I trying to say? So people understand a hemoglobin of 2, context, thank you.
Yeah.
A hemoglobin of 2 is extremely low.
Very low.
Yes, extremely low. That's going to get everybody freaking out like mass transfusion protocol right now.
Yes, but what's interesting, he actually came in, brought in by his mom.
Yeah.
He was very orthostatic. He could not stand up without passing out. He didn't have the oxygen carrying capacity he needed. Yeah. Altered. It was in bad shape, right? Yeah. But the only reason he could even survive at that low of a hemoglobin level was because of that 2,3-BPG, where he's just offloading every ounce of oxygen off the hemoglobin he had left.
That's crazy.
And so these people that have coffee ground emesis have been bleeding chronically, so they're compensating not only with their heart rate, but they're able to, because it's a chronic bleed, they can actually compensate mechanically, with like the biochemistry of the blood, they can change and add the 2,3-BPG. So, if you do have that patient with the coffee ground emesis, it doesn't mean you don't have to be concerned, but that's more of a chronic bleed. Yeah, it's more concerning with that bright red blood.
Yeah. Now with the bright red blood, because a lot of paramedics, maybe like my department, we do not have blood yet, but we do have TXA.
Yeah,
I've got a bleeding patient.
No TXA.
No TXA?
No TXA.
For the GI bleed?
Absolutely not.
Yeah.
In fact, literature has come out. In fact, 5 years ago, I taught this differently. I said, TXA okay for the upper.
Changed.
Yes.
Yep.
So now, it's tempting because you think TXA might help.
And for context, what TXA does, for those that aren't familiar, is like you said earlier, our body forms a clot over the wound. And what the TXA does is it slows down the breakdown of that clot.
It stabilizes it.
It stabilizes it so that clot doesn't go away, right? And that's why we don't give fluids. We give a bunch of saline because that will blow those clots out.
That's right.
Which is going to increase bleeding. So TXA does not stop bleeding. It helps the clot stay there longer to plug the hole until we can get them to somebody that has blood.
You're right. And by giving, like you said, the IV fluids make you bleed easier. Yeah, it increases vascular permeability, which makes them more leaky.
Yes.
It makes your clotting factors you got even more dilute. Yes. I mean, it's there's a place for fluids.
A little bit. Yep.
And I think, I haven't seen the literature in the last year or so I could be off on this, but I think a Cochrane review that I looked at said that 250 cc's of 250 cc's of blood. I'm sorry, 250.
Saline.
Let me try this again. I don't want to confuse anybody. 250 cc's of crystalloid, whether it's NS or LR, may not cause harm.
It's not going to have a positive impact, but it's not going to have a negative impact.
Maybe not.
But you go to 500 like we used to do when I went to paramedic school.
A liter.
Oh, it was 2 large bore IVs wide open. I mean, that was the
Feels
trauma
good.
care of the day. Oh, it's sea colors. I was checking the box.
Yeah.
Oh, we're going to make some people mad with the sea colors.
I'm glad you asked about TXA, though, because it's not indicated.
Well, and again,
anymore.
people would think, well, bleeding's bleeding, right? I mean, if somebody's got a traumatic injury, I would give them TXA if they're hypotensive.
Well, what's the TXA is it increases the stability of clots, right? So but it's been shown in the literature not to have any sort of benefits to mortality for a GI bleed.
For a GI bleed.
GI bleed. Right. So
if you have the hemorrhagic OB patient,
and then I hope you have Pitocin. That's the first line.
Yes.
Or oxytocin.
Yes.
Or TXA would be appropriate.
But that would be
based
appropriate for those. Yeah. Because we don't carry. I don't think a lot of flight services probably carry Pitocin.
You know, one thing that I don't think we really hit on hard enough, and I think this is one of the greatest values we have for these GI bleed patients, is determining whether or not they would be a candidate for blood. Like, are they far enough down that hemorrhagic shock pathway where blood actually would have a benefit for them? Because we don't want to give blood to every patient that's bleeding.
No.
Because we have compensatory mechanisms in our vasoconstriction, our heart, where we
clotting
have
factors.
I don't think there'd necessarily be a survival benefit for some patients to just get them to the hospital.
Yeah.
But there are some.
Yeah.
How do we determine? Like, what do we look for in the pre-hospital environment, in the back of an ambulance, to indicate a transfusion?
I like things easy. I like the shock index.
I do too.
Right? Heart rate divided by systolic blood pressure. Right? And if it's greater than 1, you've got a positive shock index. Right?
I think, and when we teach this, it's like you're in hemorrhagic shock until proven otherwise. Yes. I like to add one thing to that.
Okay.
Altered mental status. You get because if I'm tachycardic and hypotensive, but I'm able to perfuse the metabolically active brain cells that I got,
then you're still doing okay.
Yeah, and I think depending upon the clinical picture too. I mean, if you just saw me vomit up a liter of blood into a basin, and I'm tachycardic and hypotensive, the next time he vomits, he's probably going to be altered, right?
Yeah, right.
Let's act now.
Yeah. Oh,
yeah. So I agree with you. It
Anybody
depends on the
that's
context.
vomiting a liter of blood, you need to act now.
Yeah.
Let's just
if you have it.
Well, you got to do something, right? And either whether that's getting en route, because a lot of places do not carry blood, so you got to get moving.
Let's see if you can read my mind. This is unfair, Matt. So if you don't get it, it's totally okay because you can't read my mind. But there's a compensatory mechanism that we have in our bodies that we can actually capitalize on, whether you're a BLS provider or an ALS provider, and it's our legs. What am I thinking right now?
Trendelenburg?
That's right. Lift the legs up because we store most of our blood in those big capacitance vessels in our legs. You lift them up above the level of the heart, all that blood flows out of the legs to the heart, and it's almost like a transfusion right there.
Exactly. Let gravity work in your favor.
That's right. So there's a lot you can do, and hopefully your transport times aren't very long.
And if they are, call for a flight.
Yep.
They'll probably have blood. They'll probably have, the ability to do a little bit more, especially if you're a BLS provider out in rural nowhere and you've got an hour-long transport times. We get these calls all the time for abdominal pain. And we kind of think like another abdominal pain call. And then you show up and somebody's really, really sick. those patients are just as sick as your STEMI patients or your trauma patients that are bleeding out. They are bleeding out. It's the same thing that's happening. And so, yeah, you really got to be aware that don't take it for granted that you're just going on another abdominal pain call. You got to be paying attention.
And I think a lot of the cases that we've talked about are pretty obvious. And I don't think those are the ones that really separate a good paramedic from an excellent paramedic or EMT or whoever. Because I think some of the subtle presentations are the ones that are really the ones where you really are an excellent provider.
For sure.
One of the things I don't think we think about enough is chest pain. It's not uncommon to have chest pain because of a GI bleed. Yeah, the patient's been having black stools, but he or she didn't understand that that was blood. But as they lose more and more blood, the heart's got to work harder now to maintain that oxygen carrying capacity at our tissue levels to maintain perfusion. And so as the blood gets more and more thin or anemic, the heart's got to work harder and harder and harder. You get an older patient that doesn't have that kind of cardiac output ability or capability, they will present with chest pain. The heart's working so hard, they call 911 for chest pain. So you're thinking cardiac. 12
lead, yeah.
Don't forget to ask about bleeding. Because these old folks are having chest pain. This patient's tachycardic. This patient looks a bit pale. Remember, we talked about it in our we should mention this here. A window to your hemoglobin. Look at your conjunctiva.
Yeah.
If they look pale, you're probably anemic. Look at the lips, the tongue, the loss of the palmar creases, those things we talked about in our lecture. If you have a patient that's calling for chest pain, don't forget to do a thorough exam and ask about some of those GI bleed questions. It just takes a few seconds. And that might actually be the life-threatening problem. The heart's actually okay. It's just that that we're bleeding to death.
Yeah, you run the 12 lead. There's nothing on there. There's sinus tach. Like, okay, they're not having a heart attack. Well, they might have some other life-threatening condition that we're not thinking about.
Here's another case, Matt, that I thought was a really good case. I was on a ride out, and we walked in. You could smell the urine. Older person. I saw the urine bag under the pajama pants.
Is this nursing home?
No, it was at home, actually, at his home. We were called to his home. The wife was there to explain he was just released for treatment from a UTI. It smells like a UTI.
Sepsis.
They called us because of altered mental status. He's in AFib, RVR. And I'm thinking, okay, well, this is a classic setup for an infection like a urosepsis, some sort of a septic patient that triggers the AFib. It's not uncommon. In fact, you should treat the sepsis before you treat the AFib. Cardizem's not the initial treatment there. You give him fluids. Oftentimes that'll fix the AFib. But the point was, he was in AFib RVR. Everything was screaming sepsis. I mean, he's tacky in the 170s. Hypotensive.
Crappy end tidal.
He was altered. That's why they called. The leg bag's there. It smells like urine. He wasn't febrile, but certainly looked like sepsis. But he had a presumed source of infection, Well, when we were doing our physical exam, and we were so focused on sepsis. I mean, it was just screaming sepsis.
We put the blinders on.
But I noticed some coffee grounds around his lips. And I said, "Sir, have you been vomiting blood? Have you been vomiting or whatever?" And he said, "Yes." And he said he'd been having these black little bits in his vomit. And so I'm thinking, guys, this may not be sepsis. This could be a GI bleed. And so I use this as an opportunity to teach my paramedics about anchoring on a diagnosis like sepsis when you could miss a GI bleed. It's funny. I was wrong again.
It was sepsis.
No, it wasn't sepsis. Well, actually, it kind of was. Let me explain. So I get there. I'm thinking UTI sepsis. And then I see the coffee grounds around his lips. So I'm lecturing my guys on not anchoring.
As you're anchoring.
I totally anchored on the second diagnosis, right? I forgot that it could be a third. So we're transporting this guy, and every bump.
Did he have tobacco in his mouth?
No. Good guy. Do you want to guess what you think it might be? You won't guess it. We've actually already talked about this diagnosis.
Now you're challenging me. I won't guess it.
We talked about it already.
Today?
McBurney's Point. He had an appendicitis. And he had a necrotic appendix. That's actually what ended up being his worst problem.
And that's why he was vomiting.
I was so focused on teaching my paramedics about not anchoring on the first diagnosis.
Well, you were still kind of right, because at least it was in the abdomen.
But every bump, the guy, he was using profanities every time the ambulance hit a bump. And I remember thinking, is he having belly pain? So I'm pushing on his belly while he's sitting up. and I'm pushing on his belly, and he's, I wasn't impressed. And so I just kept talking about how not to anchor on whatever. Anyway, we get there, and I called the PA that was treating the patient. I said, hey, what was the hemoglobin on that guy? It was like 6.
Yeah.
So I was like, hey, we're right? And then he says, but that's not what the worst thing was. The CT scan showed a necrotic, chronic, bad appendicitis.
Wow.
So we had to go to the OR to fix his appendix and get that thing removed. So that ended
was
up
that
being
our
the
friend
most
PA?
thing.
Which one?
Beardy.
Oh, Beardy. Okay.
I love him. He's a great PA.
That's funny.
And he
I was there when he first got his first tube. Remember?
Oh,
I brought that patient in.
Oh yeah, that's right.
I remember he was so nervous, and you were standing there coaching him through it. Anyway,
So-
well, that's an interesting case. Yeah,
So
it's
don't anchor.
Very important not to anchor on a diagnosis. Yeah.
So you get that chest pain patient. Just remember to ask the questions about a potential GI bleed. I think that's a good skill.
Especially if you find nothing on the 12 lead.
Right.
There's nothing that's pointing you to this as a cardiac issue, besides maybe the heart rate's a little bit elevated.
Yep.
Right.
And there are other problems it could be too. I mean, the medicine's complicated, but just remember not to anchor on that initial diagnosis.
Yeah.
But the GI bleeds can crump quickly on you. So if you do have a bad GI bleed, identifying it's important. Identifying the risk factors. How bad is it?
Yep.
What do the vitals look like? Shock index.
Yep.
Determining whether or not they're a candidate for blood if you carry blood.
Yep.
If you don't carry blood,
no
lift their legs
TXA.
up.
Give them a little bit of fluid. No TXA. Some Zofran for the nausea, vomiting, Reglan, whatever you have. I can't think of anything else you would give them.
No, that's pretty much it. I think elevating the head of the bed. I think the airway management's big, right? So,
right. If they start getting really altered or go unconscious on you because they bled out.
That's
like
correct.
Your patient did.
And I've had to intubate patients, GI bleed patients, that get so altered they can't protect their airway anymore and they're vomiting. You got to intubate them. Yeah. So airway management's really important. I think the blood's important. We're not going to be able to reverse any anticoagulation in the ambulance, but being aware of the blood thinners is big, like you said, just asking about
and beta blockers. Yep, if you got the lulls. Well, for more information, go to our website, get the course. We go into way more detail, have a lot more graphics, and you'll get to see the leech experiment.
The leeches, we're not doing leeches here, but we'll do leeches there. It's going to be a great course.
Yeah, so. I'm really excited about it. Well, see you on the next one.
Be safe out there.
Thank you for listening to EMS, the Erik and Matt Show.